for the heroes in the global Indian diaspora like yourself. Dr. Saurabh, what inspired you to specialize in cardiology and for cardiology in the South Asian population?
That's a great question. And the roots of this go back to my seventh grade when I was studying in Pune in Maharashtra, India. My grandfather passed away from heart disease. And at this point, looking at that back 35 years ago, I would say that there is not a single family of Indian origin or subcontinent origin that they have not heard of such a story. And doctors telling me that we could not save him was a big shock to me as a kid growing up. And I said, I want to become a heart doctor. The roots were sown at that.
Hello and welcome to Indian Diaspora Podcast. This episode is going to be very important for your health. Our guest is Dr. Saurabh Dani. He is a cardiologist from the United States who specializes in heart diseases for the South Asian population. Today, we are going to understand insights from his work in the medical field of cardiology and also understand his journey in life to become a cardiologist in the US. Dr. Saurabh, welcome to the show.
Rahul, thank you so much for the invitation, and thank you so much for giving me a chance to speak on this such an important topic. And kudos to you. You are doing a phenomenal job and work to get the right stuff out for the right people and helping the Indian diaspora. So thank you so much.
Thank you, Dr. Saurabh. We are very honored to be a voice for the heroes in the global Indian diaspora like yourself. So, Dr. Saurabh, what inspired you to specialize in cardiology and for cardiology in the South Asian population?
That's a great question. And the roots of this go back to my seventh grade when I was studying in Pune in Maharashtra, India. My grandfather passed away from heart disease. And at this point, looking at that back 35 years ago, I would say that there is not a single family of Indian origin or subcontinent origin that they have not heard of such a story. And doctors telling me that we could not save him was a big shock to me as a kid growing up. And I said, I want to become a heart doctor. The roots were sown at that point. Obviously, with the fierce competition and intellect that is in India, I was lucky enough to get chosen in the medical school of my choice. I studied from BJ Medical College in Pune. I did my medical school MBBS from there. Following that, I did internal medicine residency from Seth GS Medical College, which is also called as KEM Hospital in Mumbai, and decided that the country of dreams or country of climbing ladders will be the right place for me to explore more research from cardiac perspective and learn more from the research standpoint. And that's how I chose United States to be my country of next residence to study medicine, to study cardiology. And I was lucky enough to work with various specialists here in United States as well as in India who inspired me to be the right physician, to work in a right or ethical manner, I would say, to work tirelessly for the patients and always be on the lookout to help out the community. And I think I'm lucky enough to be trained in India, which I definitely think that those were the best training days of my life, and equally lucky to train here, which allowed me to increase my horizons of understanding of heart disease. To give you a personal perspective, I came to this country to become an electrophysiologist, which is a cardiologist who specializes in heart rhythm doctors. But we cannot plan things as per our way. And I'm lucky enough for what God has given me and what is in my half cup full or half cup empty life, that I'm lucky enough to explore and understand that I can work in the space of preventive cardiology, where I could dedicate my next 15, 20 years to understand the disease in this vulnerable population and try to give back to the community that I am so much grateful for raising me what I am.
Dr. Saurabh, your journey is akin to, similar to so many Indian American doctors here. They get the best of the practice in India, but also specialized training in America. And they are proud members of the Indian American diaspora. So, Dr. Saurabh, let's come back to the topic of South Asian population, men and women. Why are we so disposed to heart diseases, genetically speaking or otherwise?
That's a great question, and that's been floating around. If you have seen the newspapers these days, in New York Times, in Washington Post, the titles of the articles are "Why South Asians Are at High Risk," and uh, the roots of this go back to the evolution. I would say there's a hypothesis called as thrifty gene hypothesis that typically Indians or South Asian subcontinent individuals require less of calories because we were always at the mercy of others for food. Unfortunately, we were ruled by many other dynasties, and there was always famine and whatnot. And then suddenly that happened for so many years, and then the industrialization or revolution caused suppression of the infectious diseases and led to increase in the problems of chronic diseases. So cancers and heart disease came. Industrialization, westernization is one of the key factors which is responsible for increased calorie consumption, increased obesity or adiposity or deposition of fat at abnormal areas in the body, which will increase inflammation. Along with that, caused a wave of having diagnosed with diabetes or pre-diabetes, increase incidence of high blood pressure. Some genetics, 25 to 30% individuals will have some genetic background to it. On top of that, unfortunately, as a community, we are not known, few exceptions apart, not known to be physically very active. So all these combined reasons could be implicated in the heart disease. What we have also now known and seen is that it's the stress which is playing a role. In addition to that, various types of pollutions are playing a key role in heart disease in this population. PM 2.5, which is a particulate matter which measures the how much air is polluted with different uh, uh, particles, and all these things add up and cause heart disease. What is peculiar is that the uh, patients or individuals who are in India or in Indian subcontinent are at high risk of all these things. But even when they move to United States or various parts of the world, unfortunately, they still carry this heavy burden of being predisposed to heart disease, having high risk factors to have heart disease, and then the presentations are varied as such. Let me give you some examples of research and what has happened on this. Typical examples are given from 1940s or so, when autopsies of patients were examined for their heart arteries and coronary arteries to figure out if they did have a heart disease. And back in 1940s, when the life expectancy was quite low in Indian subcontinent, unfortunately, because of the famines, because of the infectious diseases, heart disease was not found to be the first or the foremost disease to cause the deaths in individuals. However, now dating back to 1970s, 1980s, early 2000s, there are so many reports of the people from Indian subcontinent or South Asians being at high risk of having heart disease, high prevalence of having heart disease, high prevalence of having risk factors, and it is quite alarming.
Hmm. So you said, bunch of factors contribute. One is, the civilization history, if you will, right? Feast and famine, most of famines, calories, stress, pollution, and then moving to America, where we are inundated by more calories, right? Burgers and moving in cars, and not exercising. Hmm. This makes me reflect, Dr. Saurabh. If you look into other ethnicities or countries, let's say the Chinese diaspora or the African diaspora or people from Southeast Asia, Indonesia, Malaysia, are they equally at as much as a risk for heart disease as South Asians? Or we further stand out versus rest of the, if you will, emerging nations or civilizations, post colonial era, if you will. What's scientific community's reflections on that?
That's an exceptional question, Rahul. So thank you for asking that. Uh, as they say that we should not put every individual in one bucket and label them as cookie cutter type of approach. Let's define what is South Asian first, and then we can take that further. That what is the risk of these individuals? So, for the practical purposes, South Asians are different from Southeast Asians are different from Asians. So we have already made three buckets right there. Amongst the South Asians, and Asians, unfortunately, the South Asians who come from India, Pakistan, Bangladesh, Nepal, Bhutan, Sri Lanka, and Maldives, these countries make up most of the South Asians. Unfortunately, they do stand out when compared to other race and ethnicities. South Asians were 2 to 3 times more at risk of having cardiovascular disease or cardiovascular disease risk factors when compared globally, as well as when compared in United States.
Two to
So there's
three times more. I just want to reflect on that point. That's
uh,
that's a big statistical
it
number.
is quite of a threatening number, to say the least. And again, so let's divide the bucket of South Asians into different countries. So if you take people of Indian origin, people from India, what is their risk compared to people from Bangladesh? What is their risk compared to people from Pakistan? And unfortunately, Bangladeshis are at the highest risk of having heart disease when you just compare South Asian race and ethnicity as one big bucket. Then comes the number of Pakistanis, and then comes the Indians. So, if Indians are at twice at more risk of having heart disease than the other race and ethnicities, roughly Pakistanis are 3 times, and Bangladeshis are 4.5 times more at risk of having heart disease. And these are numbers globally as well as in the United States.
And why is that? Why are Bangladeshis more at risk for heart disease?
That's a fantastic and $1 million question. So a lot of research is going on this, and unfortunately, there's not a bigger randomized control trial or bigger prospective study putting all these individuals in one pile and follow them up for a few years to see if they did not have heart disease, what will cause them to have heart disease. But fortunately, some efforts are going on in the United States to understand the etiopathogenesis of early heart disease in South Asians, particularly Bangladeshis. And again, the factors which are typically highlighted is the diet responsible? Are there genetic factors which are responsible? Is there early onset of diabetes? Is there early onset of high blood pressure? Is there smoking? And when it comes to smoking, it is in Indian subcontinent, it is not just the cigarette smoking. A lot of people use bidi, which is a different type of
Mhm,
tobacco that is smoked. A lot of people use betel nut or pan
mhm,
or gutka, and
mhm,
all these things may be responsible for heart disease. Physical activities or inactivities can be responsible for heart disease. So, the traditional risk factors, when as a heart doctor, a patient comes to me and I look at their profile and I say, okay, you have traditional risk factors to have heart disease. By that, I mean their age is more than 55. I mean that they are males, usually more than females. I mean they have high blood pressure, and they have diabetes or pre-diabetes, they have obesity, they have stress, their sleep habits are poor, they smoke. If you take these traditional risk factors, multiple studies have shown, namely the name of the study is Inter-Heart Study, that has shown that these traditional risk factors are significantly higher in
mhm.
people of South Asian origin.
Mm,
So it is possible that the Bangladeshis have these numbers in higher proportion as
mm,
compared to the Pakistanis and Indians, which may be responsible for the early onset of heart disease. What is
mm,
peculiar? Let me touch upon that topic as well. What is peculiar about South Asian population is just not the numbers that are higher, but this is a population which experiences heart disease about 10 years sooner than
mm,
the other race and ethnicities. So by that I mean the disease is not just high in numbers, but it happens at an earlier age. The onset of diabetes is early, the
mm,
onset of hypertension is early,
mm,
and both these factors, in addition to multiple factors, just increase one's risk of having heart disease at an earlier age. So
mm,
imagine the number of lives lost from this, and
mm,
imagine the number of lives or the work lost because of morbidity which comes with heart disease.
mm, makes one think. Now, coming back to India, which is again a huge subcontinent, I love what you said. Don't put people in a bucket, right? So, understanding India, are North Indians versus South Indians, West Indians, let's say from Gujarat versus Bengal, Orissa, you know, is a particular geographical part of India or, ethnicity within India, are they more at risk for heart disease versus others?
It is difficult to say that one is more than other. Unfortunately, uh, 1.4 billion individuals in India and similar in number type of individuals outside. Uh, uh, what we have seen that the habits are different, right? You go from district to district or taluka to taluka
Hmm.
in India, or from village to village. The food habits are different.
Hmm.
The work life habits are different.
Hmm.
Unfortunately, just by being an Indian, we
Hmm.
are at higher risk by all these factors. But
Hmm.
again, it will be tough to say that North Indians are at higher risk than the South Indians. Do you blame the idli versus do you blame the samosa? That's a tough battle. Or do you blame the East or West? But unfortunately, with addition of all these factors and a lot of westernization and a lot of people ordering food from their Swiggy or Zomato, nothing against them, but
Yeah.
the habit of let me walk to the restaurant and get the food versus let me sit in front of a TV
Yeah.
and order my food and it comes in 10 minutes, including your masala chai,
Yeah.
which is going to be I think, deciding factor in how we prevent heart disease in future.
Hmm. Hmm.
But great question, and we need more
Yeah.
studies which
Absolutely.
will
Yeah.
categorize different types of individuals. Interestingly, there is a large prospective study going on in the United States,
Hmm.
and that study is also labeled as Masala study. The acronym is Mediators of Atherosclerosis in South Asians living in America.
Hmm.
So, Dr. Alka Kanaya is a very prominent researcher out of UCSF. She's an internist and a biostatistician
Hmm.
who thought of doing such a study with Dr. Namrata Kandula, who is a internist and a professor
Hmm.
in Chicago area.
Hmm.
Both of them combined the Indian population in Chicago and in Bay Area
Hmm.
and have done prospective analysis of they initially started with 900 individuals. They are now up to 2200 individuals with different grants and different studies. And dating back to 2010, their idea was to, why don't we take individuals who are living in the United States who are of South Asian origin,
Hmm.
who do not have heart disease, but can we prospectively follow them
Hmm.
for a number of years and figure out if one element was more than the other, which made them have heart disease or cause them to have heart disease at an earlier age.
Hmm.
Uh, 84% individuals in this cohort at that initial time were of Indian origin. And if we have more number of individuals from different part of India, and again different other South Asian countries, we will have a better idea as to what could be those uh, risk factors that we can pinpoint. But it
Got
may
it.
be difficult. That's what I feel.
Yeah.
We
Yeah.
may be still going back into looking at the traditional risk factors as a main reason
Yeah.
uh, to have the heart disease at a
Got it.
younger age.
Hmm. Great points. And shout out to those researchers, who are doing research on this space. Uh, just this short conversations, made me realize so much needs to be found out uh, in the space of heart diseases and how different lifestyle factors and ethnicities, they are at risk of it. I want to go back, Dr. Saurabh, to that underlying assumption about, in ancient times things were better or good, right? So, going back to, pre-Islamic era, let's say 4th to 5th century AD, where, let's say the Gupta Empire, the golden age of India, to, the eras of Mughals and Sultans, to British era, right? Broadly dividing India into those three segments. History tells us that there were mass diseases like cholera or plague, where possibly the lifespan was less than 50 years. Even if you made it until 40, you have lived a good life, and not only India, all across the world. Yeah.
Absolutely.
How could we know that somebody who outlived, fought beyond 40, would not suffer a heart disease back in the good old times? And what I'm getting to this question is that, is there something about the genes that held true back then still holds true now that we simply can't help with? Meaning, in the past, even if they lived longer, they would have died through heart disease, right? And given those genes, we'll move to the question about prevention. What can we do? But I'll come back to that later. But how do we know those who didn't live longer before, that they would have gotten a heart disease or not?
It's a very interesting and a tough question to answer. It's a simple answer. Maybe I don't know. We need more
Yeah.
studies and whatnot.
Yeah.
But taking the studies which have been done here in the United States and maybe extrapolating those, Sheikh Katisaran is a very good cardiologist and a genetic researcher in Boston area. He published a very nice paper in the most famous journal of medicine, which is called as New England Journal of Medicine a few years ago,
Mhm.
which suggested that more than genetics, it is the epigenetics
Hmm.
factors other than genetics which play a role, which may be your lifestyle, which may be modifiable risk factors such as a lack of physical activity and exercise or control of diet. 25 to 30% roughly is as a result of genetics. So that means the major role is played about 60-70% of the times is by factors surrounding genetics, above genetics, which may be making those genes expressed in a different way.
Hmm.
Uh, so having said that, dating back to many, many years ago, it is still possible that the heart disease was there, but because the population did not survive the devastation by the infectious diseases, it was not expressed.
Hmm.
Many, many years ago, heart disease was supposed to be disease of men who are
Hmm.
more than 65. And we have changed that understanding of ours, saying that now in the United States and in the world, heart disease is seen at a younger age. And it is not just the disease of men. Let's not disrespect the women in the world who are we are what we are because of the women, and unfortunately, their heart disease is equally, or if not more important, than the heart disease in men. They were labeled to have different type of pains and not pain from the heart, and they were ignored. And all these disparities are still ongoing. So heart disease in women is equally dangerous, deadly, than as when compared to heart disease in men.
Hmm.
Uh, Coming back to now, uh, if you want to find out what genes are responsible,
Mhm.
studies are going on, but simply taking care of the cholesterol profile, looking at a specific blood test which is called as LPA or lipoprotein A, which is 6 times more atherogenic or 6 times more risk of developing atherosclerosis as compared to LDL, which is low density lipoprotein, which is a component of one's cholesterol. So that can be a genetic reason why uh, uh, people from South Asian region can have heart disease. Or for that matter, is there increased prevalence of diabetes as a result of genetic factors? So that could become a genetic reason why one can develop type 1 diabetes or type 2 diabetes and be responsible for heart disease at an earlier age.
Mm.
That brings us to the topic of how, unfortunately, India is the diabetes capital of the world at this point.
Mm.
The rough numbers say that about 30 to 40% prevalence of diabetes in India itself, and similar type of prevalence of pre-diabetes. That means patients who cannot be diagnosed as diabetes, but their sugars are not normal. And we test a blood test called hemoglobin A1C,
Mhm.
which is more than the cutoff, but it's still not qualifying to give somebody a diagnosis of diabetes. So they are on the verge
Mm.
of developing full-blown diabetes. And that number is extremely high.
Mm.
And unfortunately, all this uh, combination of all these things is responsible for the genetic uh, causes of
Mm.
having heart disease early in Asians. And there are some theories about diabetes is as a result of the insulin, and pancreas is the organ which makes the insulin. So, do Indians have less number of cells genetically,
Mm.
which make insulin and cause diabetes at an earlier age? So researchers are doing a intense research on that, and we may have some answers in few years.
Mm. Great reflections. I liked what you said, Dr. Saurabh. Epigenetics, which I believe is the environment that impacts expression of the genes, right? That worry more about that more than worry about genetics, right? So philosophically, right? Don't worry about what you can't control, which is genetics. Worry or think about what you can control, which is epigenetics, which is the environment in which you are, where you can control stress, for example, or your diet. Uh, think about the oil you're having. Is that going to cause more insulin resistance and therefore diabetes and therefore a heart disease? Hmm. Epigenetics gives hope. Could you talk more, Dr. Saurabh, about epigenetics and how all the listeners could benefit about what we can control?
Uh, so we all like to blame our parents, right? This is because of my mom and dad. I'm this way because of my mom and dad, and it is okay for your looks and for your walk and how you talk, but it may be just limited to that when it comes to major diseases such as heart disease. Yes, they do play a role. I'm not going to ignore those, but the more bang for the buck can be gained if we not just focus on changing the genes or altering the genes. We cannot do that at this point. What is in our hands is um, what are my risk factors? So, do I have high blood pressure? Should it be checked every year? When should one start checking for high blood pressure? What is my cholesterol profile? A South Asian individual should have had one cholesterol profile done at least in their 20s or 30s, if not uh, in that age period. The American Association of Pediatrics takes a screening cholesterol test when kids are in the age group of 9 to 10 years. Versus when you are South Asian, you may need that test to be done sooner than the other populations as one gets into the adulthood. Do I have diabetes? And when should one start worry about checking for diabetes? And a very simple answer to that is the BMI, which stands for Body Mass Index. That means what is one's weight as compared to their height. And BMI, uh, we all know that the numbers such as BMI of 25 and more is considered as overweight. A body mass index of 30 and more is considered as obese. Unfortunately, for South Asians, those numbers don't hold true. Similar to multiple other numbers that we can talk about, do not hold true because these studies included majority of population which was Caucasians or did not have equal representation of South Asians to categorize these numbers or to come out with these calculators or cutoffs. Uh, Multiple agencies in the United States and academic bodies have suggested that the BMI of 23 is the cutoff for South Asians to be labeled to be overweight and obese. So the ideal BMI for a South Asian individual is in the range somewhere between 19 to 23. And that has to do with something called a South Asian phenotype.
Mm-hmm.
We don't have to be obese to have fat deposited at abnormal areas,
Mm-hmm.
which can predispose one to have insulin resistance. And there's a very nice article, letter to editor published few years ago, where they compared Dr. Yajnik and Dr. Yudkin. Dr. Yajnik was from Pune. Dr. Yudkin is from United Kingdom. Both have BMI of 23. And when they assessed their body fat composition, it was Dr. Yajnik from Pune who ran marathons, but Dr. Yudkin from United Kingdom who just walked to his mailbox and that was his exercise. But surprisingly, Dr. Yajnik, whose BMI was 23, was Indian, had fat deposited at an abnormal areas, and fat content was more, predisposing him to have heart disease or diabetes at an earlier age. Coming to the point, so that's why the BMI of 23, if somebody has BMI of 23, that's the screening BMI for ruling out diabetes. So we talked about high blood pressure checks. We talked about cholesterol checks. We talked about checking diabetes or screening for diabetes. Fourth, does one have prevalence of lipoprotein A? It's a very important test. It's an important blood test that primary care providers in United States, Canada can order, in Australia, in Africa, in UK can order for South Asian individuals. I know you have such a big audience, so I'm giving different countries and where it can be ordered. It is done routinely in India these days because of the increased awareness of heart disease. We need more awareness, but these tests can be done. So, and then, am I sleeping okay? What are my stress levels? Am I exercising okay? Am I overestimating how much I'm exercising? Am I underestimating how many calories I'm eating? And am I predisposed to the environmental pollutions? Yes, we don't have personal handle on that, but am I doing efforts from my standpoint to be sustainable, to help the environment, which is in turn going to help me? So those could be the few things where the role of epigenetics can come into play. That if I'm not physically active, what are the ways that I can be active? If I'm not eating healthy, and what do I mean by healthy? Is all vegetarian diet healthy? You and me both know that there's so much of oil and fried, deep frying is involved, unfortunately, in Indian diets, or the carbohydrates rich diet is going to predispose to have heart disease or to diabetes sooner. So what can I do for that? Am I doing enough efforts to log in my calories? Am I doing enough efforts to log in my exercise? Am I checking my blood pressure routinely with my doctors? Are my numbers okay? Or do I need to get enrolled in a type of a study or visit centers in United States where there is a dedicated program for South Asians to address their metabolic health? And all those come as part and parcel of epigenetics. So that was a great great question.
Yeah, things that you can control. And I want to again reflect back for the audience. You might have the same BMI, 23, but given our genetic profile, right, we might be at a higher risk. And therefore, being aware about this and constant, um, you know, measurement, course correction is needed. This brings me to this point, Dr. Saurabh, and I'll turn personal here. I know some of my friends or relatives who would say, you know, I'll turn this in Hindi. इतना क्या सोचना, you know, आज में जियो मौज करो, right? Saying this in English, like, why worry about all this constantly? I'm gonna, reduce the quality of my life, and I'm just gonna enjoy my life. So that's one perspective that many Indians bring in. Uh, Second thing we see is somebody who died at 40s. There are a lot of popular film stars in India, those who are working out in a gym or just relaxing. They were fit. I mean, these are film stars. They have good athletic bodies, and they got a heart attack in their early 40s and they died. On the other hand, there is somebody who is plump and obese, and he or she is living, beyond their 60s. So there is so much of quote unquote unfairness in how these things pan out, and I know this is a gray area. This is very difficult, right? But I'm bringing social factors here, social factors. We don't look at things statistically as a population. We look at it at individual stories. अरे शर्मा जी का बेटा तो रोज खाता है और वो मजे से जी रहा है, और गुप्ता जी का बेटा 42 के पहले ही उन्हें उन्हें कुछ हो गया, right? So there's a lot of confusion on how things pan out after 30s, I would say.
Yeah,
If you
it's
wear
it's
your
it's uh,
society and hat on, how do you? What's your commentary on this, Doctor Saurabh?
it's many patients ask me, right? And I take pride in seeing patients, and I love helping them. The question that they ask is, okay, what is going to happen to me? And nobody can tell. Nobody could tell. I tell them, give me $1 billion, and I'll tell you the exact time and date things are going to go wrong. But I totally understand with the YOLO, you only live once type of mentality. And I myself have seen patients who I thought are going to have a very severe heart disease, and I expected them to have blockages in multiple heart arteries. And unfortunately, they did not. And then you hear these incidences, and all of us have seen singer KK almost having a heart attack
Yeah,
as he was giving his performance on the stage.
yeah.
So it's going to be difficult to predict who's
Mm,
going to have it, who's going to not have it. And that is not just true for South Asians, that's true for all race and ethnicities. But what statistics tells us is the probability, right? What is the probability of something is going to happen or something is not going to happen? The higher the probability, more is the onus on us as a doctor and as a patient to come together and say, okay, given 1, 2, 3, 4, 5, 6, 7 risk factors,
mhm,
given the overall clinical picture here, the way that you look like, the way that your cholesterol is, the way that your blood pressure is, the way that your grandfather, grandmother, father, or uncles have
mhm,
had heart disease, my suggestion to you is if you keep doing what you're doing,
mm,
uh, there's high probability that things are not going to go your way.
mm.
Uh,
Got
that
it.
may be a simple way
Yeah,
of addressing it.
yeah.
Why does Guptaji's son dies from a heart attack versus why does Sharmaji's son does not have heart attack despite having all these things may have roots in the way that the plaques are made. The atherosclerotic plaques can be soft plaques and hard plaques. And unfortunately, it is so programmed by the mighty Lord, whosoever we all believe in, to have that plaque rupture at an unfortunate moment, giving a heart attack. And God forbid, if they don't have help, then that's where the cardiac arrest is the end game of a massive heart attack, where there's either a cardiac standstill or an abnormal heart rhythm,
Mm,
which comes from the bottom chambers of the heart, which is called as ventricular tachycardia, which makes you suddenly collapse.
mm. This brings me to this topic, Dr. Saurabh. I think this will be useful. So, when we say heart disease, an average person might think heart attack, right? I myself worked in the field of ultrasound in heart. So, that's when I personally discovered there are different kinds of heart diseases. There is heart failure, there is structural heart diseases, right? There is the right ventricle. You know more than me, right?
No,
For an
absolutely.
average
And
audience, how would you categorize the kinds of heart diseases they can get? And all this will lead us to the next topic of prevention. But let's understand heart diseases.
yeah,
What are the kinds of
absolutely.
heart diseases?
It's a great question because there are so many misconceptions about what do you mean by heart disease. So again, let's put everything in the bucket of cardiovascular diseases. Cardio is heart, vascular is the blood vessels. So it's a combined bucket of having heart and blood vessel related diseases. So heart is a muscle bag. It's a pump. It pumps and relaxes. Pumps and relaxes happens even before we were born and continues until we die. I call it womb to tomb pumping. But the heart muscle needs blood supply. So there are blood vessels which supply the heart muscle so that it can remain nourished and it can keep pumping for years together. So when the blood vessels of the heart, there are typically three blood vessels in all of us. These three blood vessels, when there is a blockage um, as a result of atherosclerosis or increase cholesterol numbers or LDL or lipoprotein A or early onset diabetes, these blood vessels start to develop blockages from within inside. Imagine your kitchen sink pipe. When the kitchen sink pipe keeps draining, after a few years, it becomes oily from within inside.
Hmm,
That I describe as atherosclerosis,
hmm,
the oil from within inside, which starts, and one fine day, the kitchen sink pipe stops draining because there's clump of oil that prevents it from draining. Take that to the heart. When a clump of atherosclerosis, a clump of blood clot, clump of cholesterol plaque switches the blood supply to the heart muscle completely in 1, 2, or 3 tubes, that's a massive heart attack. Patients usually will have chest pain, they will start pouring sweats, they'll feel that this is the end of their life because they have never had such kind of pain. Many patients do develop shortness of breath, uneasiness, feeling of doom. That's a heart attack because the pipe is completely blocked, and the heart attack is nothing but the cry of the heart muscle demanding oxygen, demanding blood supply. So, this is a heart attack. This is the commonest form of heart disease. Like I said, the heart is a muscle bag. It pumps and relaxes. The signal for it to pump and relax is given by the electrical system of the heart. So there are electrical wires in the heart which are programmed by nature to make the heart contract, get the heart the signal to contract and relax. If there is a problem with these electrical wires, one gets heart rhythm related problems. So there, people must have heard that some of their relatives got a pacemaker. Pacemaker is given because their heart rate was too slow because this electrical wiring system was not functioning appropriately. Or the reviewers may have heard that some of their relatives have had arrhythmia, abnormal heart rhythm. And so in abnormal heart rhythms, the problems are with this electrical wiring and or the abnormal foci, areas of the heart starting their own electricity. And that can have various causes as to why that happens. Atrial fibrillation is the commonest heart rhythm in the world and in the United States, which is an irregular heart rhythm that happens as a result of abnormal electricity in the heart. So these two are major heart diseases. Then comes hypertension. High blood pressure is a heart disease. Stroke, by that I mean blockages in the arteries in the brain as a result of a clot or as a result of a bleed, decreased function of the brain, causing paralysis of one limb, other limb, or speech. That is a form of a cardiovascular disease because the blood vessels are affected. Congestive heart failure or heart failure simply is a disease where either the heart muscle is weak from a heart attack or from a genetically origined heart muscle abnormality, or the heart muscle is stiff as a result of increased blood pressure, kidney problems, increased weight, increased lung problems, making the heart muscle difficult to relax. And so that's the spectrum of heart failure, where the heart muscle can be weak from a heart attack or some other cause, or the heart muscle becomes stiff as one gets past 65, or if they have multiple risk factors, namely diabetes, namely obstructive sleep apnea. There's a condition where people stop breathing in the middle of the night because there is an airway obstruction, the way that the neck is, or way that their weight acts on them. So all these risk factors can predispose one's heart to become stiff. And in the United States, we are seeing that there is an equal distribution, by meaning 50% individuals have stiff heart and 50% individuals have weak heart who present to the hospitals, and is a very common reason for hospitalizations in this country. So that can be roughly the spectrum of heart disease. And if the legs, the blood vessels in the legs are compromised as a result of smoking or as a result of atherosclerosis, then that is called as peripheral arterial disease. Again, comes in the bucket, the big bucket of cardiovascular disease.
Got it.
And mind you, the sudden cardiac death or cardiac arrest can be end result of many of these problems. If the heart muscle does not get blood supply, sudden shut off of blood supply, that can cause a cardiac arrest from an abnormal heart rhythm. Or if one has weak heart, their weak hearts can also initiate abnormal heart rhythms, causing heart to stop suddenly or to beat excessively, making someone collapse. All of us have heard about Damar Hamlin, the athlete who had cardiac arrest last year. That was a treatable cardiac arrest because of a different condition altogether, where the injury caused his heart muscle to beat in an abnormal fashion.
Wow. You said it so well. Womb to tomb, the muscle in the body that keeps on working. And, it's an involuntary muscle and we don't think about it, but it plays such an important role and so many things can go wrong. But, with prevention, we can correct it. And I'm so eager to come to the topic of prevention. But one more topic I want to reflect on. I think this will be useful. The diaspora, right? So there are two kinds of Indian diaspora: one who were born in India, who were raised there, right? Meaning they faced the pollution in, let's say, in Delhi, right? They had food in India. Diwali just passed by. They had sweets in India. So they grew in India, and then they moved to US, and they're living there for 20 years. They moved to UK. They moved to Australia, right? So that population. The second in the diaspora are second, third, fourth generation, right? Indian American kids born in Ohio, born in San Francisco, or third generation, Fijian Indians, those in Trinidad, Tobago, Guyana, Suriname, Kenya. Do we know, is there a difference in risk profile for heart disease for these three segments? Number one, and very practically speaking, if somebody from India is watching this and, when they would move to the US and live there, right? What have you observed or studied how, their risk factors change? For example, there might not be air pollution here, but the hormones in the food, in the meat, right? Does that cause more insulin resistance, for example? So some reflections on diaspora migrations and the three generations of diaspora, Dr. Saurabh.
That's a fantastic question again, Rahul. You are making me think. So that's thank you for that. The waves of immigration are responsible for many things here. The initial waves of immigration from India were to Africa, Canada, and UK before the independence. And after independence, it is more of United States in 1960s and 1970s. Acculturation is the term used for individuals who have lived in different country and then they get used to the new environment or become part of the new culture. And does that play a role is an important area of investigations. And the masala study, which is ongoing, has told us a lot about it and will tell us a lot in future because there is a masala 2G second generation. So these are the second generation Indians who are born here to Indian immigrant parents or South Asian immigrant parents, and their study is ongoing at this point in Chicago and in Bay Area. What I've noticed, personal observations, people who come here or came here earlier in 1960s, 1970s, they came here for education more than the latest wave of immigration where people came here only to work. And that has to do with the socioeconomic status of these individuals. So people who came earlier, they were either engineers, professors, ITs. I'm not going to typecast, but again, the observations of those. So they adapted to the healthy life here. So people who are not exercising now, suddenly you're seeing a wave of people who are exercising, doing various types of exercise. But at the same time, they also got exposed to the diet. When I came here to this country 18 years ago, the bowl of Chipotle was too much for three people. Now one can finish it in 15 minutes. That is part and parcel of acculturation, where the quantity of food has increased, the type of food or the meat eating may be increasing depending on if you're a meat eater, not a meat eater. At the same time, the processed food and intake of that is increased. So the obesity is increased in these individuals. At the same time, the type 2 diabetes or incident type 2 diabetes is higher. We know that even if you immigrated to this country or if you're born in this country, those studies are ongoing. With regards to pollution, totally get that the air pollution is too much to handle in India, but the things are not different here in the United States either. There's so many pollutions that we don't even take into account are playing a role, silent role, each and every minute on our lives. There's lead exposure, there is secondhand smoke, there is particulate matter still being exposed to our bodies, which is going to increase the risk of a heart disease. Does the exposure that somebody carried in India go away? We don't know. I don't know, and studies would be required to uh, uh, study its effect. But these are all interesting facts, and I don't have answers. And that's how a lot of people are coming together. Clinicians are coming together in United States, understanding that the South Asians account for 24-25% population of the world. And
Hmm.
unfortunately, 50% of heart disease is amongst these individuals in the entire world, which is a very eye-opening number.
Yeah.
And
One
that's
more
how,
statistic of 24% of the population, 50% get heart diseases, and we are 2 to 3 times at risk of heart diseases, right? So, I mean, this should be at the forefront of government policies, health policies. We should be
it
talking
is.
more about this, right? And I'm
It
sure
is,
we are. Yeah.
that's a great point and a great segue, because a lot of eyes have opened now as a result of these longitudinal studies, as a result of these numbers, and the government policies and thinking has now come to the level that a couple of years ago, Pramila Jaipal
Hmm.
has passed a legislation in the House about the awareness of heart disease in South Asians
Hmm.
and what can be done for research. A similar type of legislation in the Senate was introduced by Senator Brooker earlier this year. So efforts are going on. And to that end, let me put a personal plug here. The efforts are going on in the country on different levels. Let me take you to the metabolic clinics, which have been started in various parts of the nation in the United States. Uh, there are clinics in the Bay Area, there are clinics in the Chicago area. I'm proud to be one of the co-founders and directors of a first ever South Asian metabolic clinic in Massachusetts. I work at Leahy Hospital and Medical Center in Burlington, Massachusetts. And about 1.5 years ago, we started. This is the largest clinical program seeing patients of South Asian origin to diagnose them or to talk to them about prevention and what kind of preventive strategies can be talked about. We take pride in seeing all these patients. So please feel free to contact and get in touch with us if you want to be checked out for heart disease. There are clinics in John Hopkins. There are clinics in Dallas, and in Dallas, Texas area, the largest registry of patients, and that is rightly called as Dilwale, which is about 31,000 patients. And one of our colleagues, Dr. Anandita Kulkarni, is leading that effort. Dr. Jaideep Patel is leading the efforts in John Hopkins. So there are many like-minded individuals geared up to help the community, understanding that by 2050, South Asians are going to increase exponentially in this country. Currently, it is estimated that about 5.5 million individuals of South Asian origin are residing in the United States. These numbers are going to exponentially increase by 2050, making us the caretakers or caregivers of these individuals. So, mammoth efforts are ongoing. We still need more efforts on various parts, not just the government policies, but energized individuals and physicians and researchers
Hmm.
looking for opportunities to work towards this.
Hmm. Well said, doctor. What's the name of your clinic once again?
It's called a South Asian Metabolic Program.
South
So
Asian
it is,
Metabolic
yeah.
Program. Okay, got it.
The unique feature of the program is we are not just the cardiologist. We have an endocrinologist to deal with your diabetes or find out if you do have a diabetes, or uh, what can we do to prevent you from developing diabetes. We have a kidney doctor. We have a stroke doctor. We have many surgeons who take care of cardiovascular surgeries. We have many electrophysiologists who are heart rhythm doctors, designed to understand your heart rhythm problems. And we have interventional cardiologists who are doctors ready to put in stents in different areas if they are needed. On top of that, we have 11 different languages spoken amongst us. So when you want to take the culturally sensitive advice or understand what they have to want to talk to us, it is important to understand the language. We also have a dietitian who's of Indian origin, because it's important to understand what type of diets that
Yeah.
they're eating. Someone else of different culture may not understand what it means to eat dal, paneer, and have the butter naan. So all these things are important, and we are doing targeted efforts, gathering the data from various features of their blood tests as well as radiologic tests, their calcium score. A lot of our viewers may have heard about calcium score. It's a CT scan of the heart to find out if the atherosclerosis has already started, and it is considered as one of the screening tests at this point to decide lipid lowering therapy or decide higher level of management of heart disease. So it's an
Mm,
important test, and we routinely get that test done here.
mm. Excellent. Shout out to the your entire team there, Dr. Saurabh, working in different areas, all for the South Asian population. Moving on. Finally, prevention, right?
Yes, yeah.
So we reflected that yes, we are at risk. We talked about, you know, sab chalta hai, nahi chalega. Yes, we have to pay attention because it's about managing over long term. So that brings us to prevention. Um, I want to set the outline for prevention, right? One is, let's say, Western scientific techniques, you know, right? Second is, because we are South Asian, the Eastern techniques, be it Ayurveda, pranayama, yoga, whatever, I don't know. And the third possibly is nutrition, food, diet, what else we could do, right? So, and maybe I'm missing something, but let's first possibly start with the Western, go to Eastern, and then food and diet. But I leave it to you.
Yeah, so an ounce of prevention is better than anything else. Let's start with that. So,
Hmm.
if we're not doing anything, today is the day, or yesterday was the day to start your preventive activities. If you're of South Asian origin, it is that important. So, what it means to prevent something, right? So, what are you trying to prevent? You are trying to prevent the heart disease. You're trying to prevent the risk factors for the heart disease. So let's talk about risk factors for the heart disease. So if I'm 25, 30, is my blood pressure checked? Is my blood pressure normal? Is my blood pressure high? If my blood pressure is high, what are the ways that I can reduce the blood pressure? Is the diet, which is rich in carbohydrates, rich in salt, rich in oils, making my blood pressure high? Or is it my overweight condition which is making my blood pressure high? Or do I have this condition called obstructive sleep apnea, that I'm not breathing in the middle of the night because my airway is obstructed? These can be simple things to look at, right? Everything is intertwined. It is difficult to tease out one from other because they're all uh, uh, same spokes of the wheel, to say. Uh, so, simple measure of checking the blood pressure, documenting the blood pressure. All of us in the United States have fancy watches, smart watches, smartphones, logging your number, and not just depending on that one physical visit with the primary care doctor, who may or may not have the time to give you to answer all these questions. And unfortunately, the understanding that South Asians are at high risk of having heart disease is not permeated to all the ground at this point. So there may be many primary care providers who may not have this knowledge, that there may be uh, more vigilance that needs to be paid for such individuals, which is a fact that we see in practice. Then comes the role of the cholesterol. So is my cholesterol high? Is my cholesterol low? Is my cholesterol normal? Is my cholesterol normal? Is it normal for South Asian? Because, like I said, the many parameters that we use as cutoff values have never included South Asian diaspora to the extent to make that generalized statement about them. So, for example, we already discussed about the BMI, the body mass index of 23 and less is better for South Asians. Hemoglobin A1C may need to be less than 5.5, or the LDL, which is the bad component of the cholesterol, may need to be less than 70 if you're a South Asian, or high risk features. Many in the agencies ask for it to be 40 or 30. And that has been a paradigm shift over the last 20 years in our understanding of cholesterol profile for all populations. So now when you're focusing on South Asian, you have to be more careful, more stringent, more focused about lower is better for the LDL. And
Hmm.
then, if my BMI is 23, have I been checked for diabetes? Do I have diabetes? Do I have pre-diabetes? What are the things that I'm going to do to prevent developing full-blown diabetes. Type 2 diabetes is a preventable disease. Ultimately,
Yeah.
heart disease is a preventable disease.
Yeah.
So, is that exercise going to help me? Is that diet change going to help me? Is plant-based diet going to help me? Stopping alcohol going to help me? Do I smoke? Do I need to stop smoking? Do I chew the pan, gutka, bidi? Do I need to stop that? If I'm not indulging in at least 30 minutes of regular brisk exercise, walking, aerobic exercise, weight lifting or muscle strengthening exercises, accumulating to 150 minutes on a weekly basis, then how can I start?
Hmm.
There's always a start, right? If you don't start today, you would not start any day. So you had to start yesterday.
Hmm.
So that will come into play.
Hmm.
And then, if unfortunately you do have all these things abnormal, then are you getting enough help, sufficient help from the doctors to work with you? And I
Hmm.
always call medicine as a game of tennis. That doctor is one person hitting the ball, and I want the patient to be returning the ball from the other side. Can we work as a team together
Hmm.
and say that, okay, let's chalk out a plan for you to reduce your hemoglobin A1C from 7.5 to 6.5 in a span of 6 months, 3 months? What are you doing? Are you sleeping okay? Are you stressed out? Are you eating the right stuff? Because plant-based diet is the best, but if that is carbohydrate rich and deep fried, it is not going to help you. If it is processed, it's not going to help you. The whole grains are going to help you. The fruits are going to help you. The green vegetables are going to help you. Spices may or may not help you. So this needs a very dedicated approach for the prevention strategies. And then I see so many unfortunate individuals who come to me saying that, hey, my calcium score is already 700. My heart arteries have already shown heart disease, and I'm 45 years of age. And that's a surprise and a shock to many. So then, what are the ways that you can keep that calcium score 700, or can you reduce it? Is there a way to reduce it? Is there a way to prevent it from going to 800, 900, 1000, or causing a heart attack? So, what are the means there? So, are they getting the right medications? Are they getting an aspirin? Are they getting cholesterol lowering medication? Are they geared up to losing weight, doing intermittent fasting? Are they geared up to check their hemoglobin A1Cs and make sure that their doses of diabetic medications are coming down and not increasing?
Hmm.
Uh, so there are modifiable factors and non-modifiable factors. The genetics we cannot modify.
Yeah.
The lipoprotein A, which is very highly prevalent in South Asians, is an important blood marker, as we alluded to, which increases one's risk of having heart disease 6 times than just the LDL. We don't have current treatment which is geared towards lowering the lipoprotein A. Studies are going on. But then, in that meantime, can I reduce my LDL, which is the low density lipoprotein, to the lowest possible degrees? So, all this is part and parcel of prevention.
Yeah.
Things that I can modify with the help of a doctor, things that I don't modify, but I'm not going to focus on I cannot modify this at all, but let's focus on what I can modify to get the maximum results, will be the key.
Hmm. Got it. So we sort of, saw the, Western approach is basically measure, 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 right? If you can't improve if you don't measure. The Eastern approach, I would say, is plant-based diet, but watch out, right? Um, Yoga, Ayurveda,
Tremendous role. It's a great topic, and there is multiple research going on all aspects of cardiovascular health. Extremely important. Yoga, simple breathing techniques and exercises are important for stress, relaxation, and elevation. Different types of the intensity of yoga is going to help you with high blood pressure. It's going to help you with atrial fibrillation. It is going to help you with reducing the stress levels and ultimately get your blood pressure down and make you calm, quiet, and
Hmm.
decrease the chances of abnormal heart rhythms.
Yeah. There's a 3-4-5 technique, or 4-5-6, whatever, right? Breathe in, hold your breath, relax, slowly exhale. That calms you down. Basically, be away from stress.
And then we have so many resources these days that we need to make use of this, right? This is
Yeah.
a democratization of information. We are in the era that so much of information is available, good and bad, but again,
Yeah.
the onus is on us to choose the right
Choose the right one.
for us. And so many resources that we are ready to provide as clinicians, and
Yeah.
freely available on different platforms that we need to use. This is an art that our ancestors found many, many thousands of years ago, that
Mm.
we need to sustain it by doing these efforts and help ourselves.
Absolutely. On the point of measure, I'm sort of going to bring in the healthcare system element here, right? So India, has a famously practical, this works healthcare system, right? A lot of hospitals, they provide whole bodies examination package, for example. I remember when I was in India recently, as part of one of the hospitals package, I had an ultrasound examination of my heart, right? When I go to a normal health checkup here, they do the blood examination, but not an ultrasound, which I assume it will be expensive in the US, right? So, for somebody, who doesn't have a good insurance plan here, in the US, we have, very high healthcare costs, right? What is a practical advice, for possibly at home monitoring? For example, diabetes can be monitored at home, but how's your health? How could you monitor at home first? How could you measure first, right? And then possibly through your regular healthcare checkup, second layer. And the third is specialized. So you're here in Boston, but what if somebody is in Nebraska, or somebody is in Iowa or Wisconsin, where such a clinic is not there and they can't travel? So
Yeah,
how
it's
can
a
we democratize measurement and monitoring of your heart?
That's a very important question, and thank you for bringing all these disparities to the forefront. And even when we are in the United States, we see this division where few people get it, few don't, and unfortunately, insurance. And there's a very nice dictum which says, "Wealth brings health." So if you are a person of a good socioeconomic status, you are going to get more help, and your longevity is more. Unfortunately, that is proven a few times ahead of us. Yes, from preventive standpoint or major standpoint, blood pressure, all of us can measure blood pressure. There are very simple blood pressure machines which are available to be widely used. They're not expensive, anywhere between $50 to $100, depending on how much degree of completeness you want. But these are simple blood pressure measuring cuffs. You don't need a stethoscope to measure a blood pressure, so that can be measured at home. So any individual who's more than 30, at least when they go to the doctors, at least one blood pressure reading with their doctors, and frequently once a month, if it's not a bad idea to check the blood pressure. As one gets older, maybe more frequently, because blood pressure is a silent killer. You're not going to experience the symptoms of it until something catastrophic happens. Uh, so that may be an easier way. Checking the weight may be an easier way. Again, most of us in the United States do have a weighing scale in the bathroom. It's very important to have that, to keep an eye. Keep an eye, right? Does not mean that it's a shaming thing or whatnot, but at least I need to know my weight. There are many advanced scales, and again, I don't want to advertise anything here, but there are many scales which will give your percentage of body fat and percentage of muscle mass, and use that as a guidance. You don't think that that's the only line in the sand, but that can be used as a guidance. That, hey,
Mm.
this is my percentage body fat, and let me work out for 1 month and see if my body fat goes down, my water content and my muscle content, does that increase? So that can be a self generated way of monitoring one's weight. Sugar monitors, most of us, when we go to primary care doctors, will get a yearly check uh, of the fasting sugars, hemoglobin A1C, which is a blood test measure of last 3 months sugar, is readily available. And it's part and parcel of preventive care. And we can ask our providers that, hey, is it possible to get it done? And they'll be happy to order it. So that can be easily done. An EKG or electrocardiogram, not necessity, but can be done if you're 35, 35, 40, if you request to primary care. But again, the cost of it, many insurances cover, many don't. It may not come under the preventive workup. Same is true for ultrasound or echocardiogram. The tests are quite expensive in the United States. We know that. So versus in India, where you can pay out of pocket and get the test done in a facility of your choice. So that's a big difference there. Uh, Having said that, a lot of glucose monitors are available to be bought these days. I wear one from the Abbott company, and I monitor my glucose. It's a continuous glucose monitor because I'm at risk from my parents' history. So I want to figure out, yes, is it expensive? It is slightly expensive, but that's the cost that one can pay to be vigilant and prevent from developing the diabetes and its downstream effects. uh, Readily available. You don't need a prescription now in the United States to get a continuous glucose monitor. Again, you will find various things on media. Do normal people need it? Don't need it? Again, it's a personal choice. But if
Mm,
you are geared up to do better,
mm,
maybe one resource that can be used. Stress tests are not needed routinely. uh, if somebody is not symptomatic, one does not need a stress test to figure out if their heart arteries are normal or not. If you're doing exercise every day, that is your stress test every day. That is needed. Exercise is needed to increase the blood vasculature and increase supply oxygen to the heart muscles. That also allows these blood vessels to keep running and keep flowing the blood. um, the calcium score, which is an indirect way of finding out if somebody has calcium or no calcium, and a nice way of looking at it is power of zero. Dr. Nasir Khurram, who's at Houston Methodist, has done a lot of work about coronary calcium score.
mhm,
And if calcium score is zero, there is about 1 to 3% chance that they still may have problems, but
mhm,
safe to say that you're at a good place at that point. But don't quit on your preventive measures. Don't quit on what you're eating. Don't quit on the plant-based diet. Don't quit on your regular exercise and checking everything.
mm,
uh, Calcium score can be repeated every 3 to 5 years based on one's risk profile to see if they're developing something. Medications are important. If your LDL is high, if you have family history of heart disease in your mom, dad, or if they unfortunately passed away from heart disease in their 30s, 40s, 50s, one becomes a candidate to take a lipid lowering therapy. And modifications have been done in recommendations to include South Asian race as a biggest risk factor to have heart disease. So that is an important concern that medications do work. Statins do work to reduce the LDL, reduce the inflammation. So those can be few measures that one can take. Again, uh, stay away from processed meat, stay away from alcohol, stay away from smoking. What can I do for plant-based diet? Does intermittent fasting work to lose weight? And from personal experiences, it does. For many of my patients, I myself lost a lot of weight by intermittent fasting, and it is at this point I find it a good way of supplementing your lifestyle to get on better road for health.
mm. Thank you, Dr. Saurabh, for sharing your personal experiences as well of intermittent fasting and glucose monitoring, right? So, bottom line, measurement, but early measurement, right? Yes, in the US, we might not have quick access to an ultrasound, but definitely blood sugar monitoring, and basic monitoring will let you know weight, for example, will let you know where you stand, literally. Okay, this brings us to the last segment, which is rapid fire. This was a very useful discussion so far on how to take care of your health, prevention. We'll wrap up with you personally, Dr. Saurabh. So my first question for you is: if you were not a cardiologist, what would you be?
Musician.
Talk to us more.
Yeah, so I learned and trained to play tabla. It's an Indian instrument, all of us know, for about 15 years or so. And I used to be part of orchestras and different groups. Music is one which rejuvenates me at 2 o'clock in the morning or at 5 a.m. in the morning. I cannot live without music. I am a very big fan of Indian classical music, but any music and good notes excite me, make me happy. I feel like I run on a rhythm. So I would have been a musician or a poet.
Wonderful. Next question. Vada pav or McDonald's burger?
Vada pav, Amchi Mumbai.
Excellent.
Yes, the cheating is allowed when you go to India once.
A balance.
Because
Yes.
as you know, that potato and vada pavs are deep fried, not heart healthy at all. But if I make a trip 3 times in 16 years to India, I will eat that vada pav.
Next. Um, a doyen, a great person in the cardiology field that you really look up to.
It is Dr. Deepak Bhatt. Deepak Bhatt is an amazing individual. He's a cardiologist, interventional cardiologist who used to be in Boston and now is in Mount Sinai in New York. Tremendous researcher, very good human being, always available to talk to, always available to guide, and a stalwart.
Next. People from which country are acing heart health?
Tough question.
Yes.
Maybe the Europeans. I don't know the Europeans. And people from Denmark, maybe I'm just making this up, but
Yeah.
maybe, yeah.
Possibly. Yeah. Good to study them. Next. One food Indians must absolutely give up to take care of their
Gulab
health.
jamun. Gulab jamun.
Every Indian restaurant has it.
It is so sweet, so sweet, so sweet. These sugar balls are cannonballs aimed at your heart.
Love it. Love it. Well, that's all, Dr. Saurabh. Thank you for sharing your rich insights. I mean, you are dedicating your life to this field. You're so passionate about it. And as you said, this demographics of South Asians, not only in India, we are the largest population in the world, but also internationally and in the US, we're going to increase. And so great a cause and a purpose to dedicate your life towards serving this demographics. So thank you, Dr. Saurabh. Finally, if there's a message for the entire diaspora from Australia, New Zealand, Africa, Europe to USA, Canada that you would like to give, what would that message be?
Let's stay united. There's enough fighting going on already. Let's stay united. We have common culture, common languages, common understanding. Let's be together.
Lovely. With that,
Thank you
Dr.
so much,
Saurabh,
Rahul. Thank you.
yes,
Thank you for this opportunity. And you have hit all the right chords and right things about this important and critical topic. And thank you for making me think. And thank you for this chance.
thank you for your dedication to this field, Dr. Saurabh. Thank you. Take care.
Thank you.
Bye bye.
Yep. Bye.
All right.